Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the 6th webinar in Arthritis and Osteoporosis Victoria's 2015 Musculoskeletal Health webinar series. Tonight's webinar is on the subject of gout, given that the prevalence of gout in elderly male Australians is second only to New Zealand, which has the highest reported rate of gout in the world. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message for the staff at Redback Conferencing at any time. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of her presentation, you can actually type questions for her at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Eastern Standard Time. I would also be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey. It'll only take you approximately 30 seconds to complete. Our presenter for tonight is Dr. Tina Racunica. Tina is a consultant rheumatologist and the Director of Southern Rheumatology, her private rooms. She treats adult rheumatological conditions, including the inflammatory arthritis, other connective tissue diseases, musculoskeletal complaints, and osteoporosis in both her private rooms and at the Alfred Hospital. She is also qualified in musculoskeletal ultrasound and incorporates this into her practice. Without further ado, I'll hand proceedings over to Tina. Thanks very much, Tina.
Good evening, everyone. I'm going to talk to you about gout, and in particular the diagnosis and management of gout. And that's because gout is common. It's 1.5% of the Australian population in a recent study. It is 5 times more common in men, and it is increasing in both sexes with age, so that at a male over 65, there's about 5% prevalence in males at that age. Now, it is an ancient disease. We know a lot about gout. But despite that, it is poorly managed. A recent study showed that over a 5-year period, only 22% of patients achieved the target serum urate level of less than 0.36 millimoles at any one time. That means that 80%, or 4 out of 5 patients, are not achieving that target level and are probably still experiencing gout attacks. Everyone would have heard of some myths and misconceptions regarding gout. Today I plan to discuss some common misconceptions and present the 5 rules in gout management by using some cases to illustrate this. Treating gout effectively can be quite tricky sometimes, so I hope to give you some directions for some effective strategies that may help. And as well as this, I wish to discuss some new pharmacological treatments that are available on the horizon. So the first case is Mr. AB. He's a 49-year-old male labourer, and he presents with 2 days of an extremely painful swollen left ankle. He's otherwise well with not taking any regular medications. He drinks 2 to 3 beers a day and 12 on weekends. He'd had a similar episode to this in his first big toe, the first MTP joint, 6 months ago. So we typically call this podagra. He took some ibuprofen and it settled after a few days. He has no history of renal calculi. He currently has no fevers and no recent infection. When you examine him, his vitals were all unremarkable. He had a hot, red, swollen left ankle. It was exquisitely tender and limiting in his range of movement. He had central adiposity, and otherwise his examination was unremarkable. His urinalysis was also unremarkable. So what do we do next? So the first thing I would recommend is that you aspirate the joint. So either if you do it yourself or you send them out to get a joint aspirate under radiology or your friendly rheumatologist to aspirate the joint if possible. And there's 2 reasons for this. The first is, in someone who has a monoarthritis, you need to consider septic arthritis. Now sometimes it's pretty obvious it's gout and you don't need to do that, but you need to at least consider it. And the second reason is that you really want to try and prove gout by an aspirate if that hasn't been proven before. So just a few notes on septic arthritis. If it is a monoarthritis, you should at least consider it. You need to consider the risk factors that might lead to a septic arthritis, such as a cut on the foot, such as an ulcer, for instance, If they've got fever, they're quite unwell, if they've had a recent infection, then you need to try to aspirate the joint and prove that it's not septic arthritis. It can be tricky sometimes in regards to an aspirate, especially if it's a small joint like the big toe. It can be done, but it is a lot harder. So sometimes you really want to try and prove gout on a bigger joint. In terms of septic arthritis, you can actually get septic arthritis on a gouty joint, so you can get urate crystals as well. And also, in a septic arthritis in someone who doesn't have gout, you can occasionally get the odd uric acid crystal as well. Now with joint aspirates, cultures are only positive in about 80% of cases, and also gram stains may only be positive in about 50% of cases. So it can also be tricky when they're false negatives. And what do you go by then? Well, you can go by the white cell count. If there's a lot of polymorphs, over 25,000, if they're 90% neutrophils, then you would consider septic arthritis. Again, medicine's not 100%, it's not black and white. So pseudo-gout, for instance, or even a good-going gout can give you a higher polymorph count than that. If it's a low polymorph count, you need to also consider that if they're neutropenic or immunosuppressed, they may not have a high polymorph count. So these are all considerations in terms of when you are doing a joint aspirate and wondering if it's infection. Certain bacteria, Mycobacterium, Neisseria gonorrhea, certain gram negatives can also be culture negative as well. So just in terms of proving that it's gout, you really want to try and do the aspirate to show monosodium urate crystals if possible. If you can't, then the diagnosis is supported by podagra, so first MTP joint inflammation, the presence of tophi elsewhere, such as at the pinna of the ears, over the joints at the elbows are classic sites. Classic image findings on X-ray, for instance, such as the tophus that has eaten away the bone and given a large erosion, or if they've had a good response to culture seen. So these are all situations where it would support the diagnosis of gout. A high serum urate is not supportive of the diagnosis of gout. You need to show monosodium urate crystals. So the rest of the investigations, in our case, he has a high CRP of 120, he has a neutrophilia, he has normal urine and liver testing, and his serum urate is in the normal range. His lipids are normal and his blood sugars are normal. So this leads me to the second rule, and that is that you need to consider risk factors to why this person has gout, whether he has metabolic syndrome, for instance. It's also recommended to check the renal function to see if there's a risk factor in terms of renal impairment, cardiovascular risks, and also medications that can sometimes bring on gout, such as Lasix or furosemide. So he had a joint aspirate. He had uric acid crystals in the aspirate. His gram stain was negative. He had polymorphs of 21,000, few red blood cells, and no growth after 24 hours. So it can be pretty comfortable that this is gout that's causing his joint inflammation. So then how do we treat? There's two principles in treating gout. The first is to settle the acute inflammation, and the second is to rid the body of monosodium urate crystals and reduce the load. So in the management, we start with education. We're going to educate the patient on the nature of gout, the risk factors, dietary restrictions, and give them an attack management plan and a goal of treatment. And I'll come back and discuss those in a moment. We also want to treat the acute attack. So we can do joint injections with corticosteroids, which usually work quite well. We can do anti-inflammatory medications if not contraindicated. And it really doesn't matter which anti-inflammatory you use. So history, indomethacin has been the traditional drug used, but it doesn't have to be indomethacin. It can be 1 gram of naproxen. It can be diclofenac, 50 milligrams 2 to 3 times a day. It can be Celebrex, 200 milligrams daily. All are effective. And we can also use colchicine. So colchicine traditionally was given 1 tablet every 2 hours until you achieve diarrhea. Unfortunately, that causes a lot of toxicity, and there's been a new regimen that's been recommended since 2010, and that is that you have 1 milligram or 2 tablets straight away, and then 1 milligram an hour later, and then 1 milligram twice a day or 3 times a day thereafter, maximum of 2 milligrams a day generally. So that's how you would treat the acute attack with colchicine. We can use prednisolone. Doses 37.5 milligrams or 25 milligrams sometimes is sufficient. I'll come back and talk about that a little bit later. And then interleukin-1 inhibitors. We did briefly have an interleukin-1 inhibitor in Australia for the treatment of rheumatoid arthritis, and that was anakinra. Unfortunately, we have better drugs than that, the TNF inhibitors, for instance, and anakinra was taken off the market. Canakinumab is another interleukin-1 inhibitor that is available overseas. It's been shown to be as good as a cortisone injection, but it's expensive and it's not available in Australia yet. We may well see it in the future. So, rule number 3, the acute management: educate the patient, manage the risk factors, write an acute attack plan, and manage the acute attack. So I'm just going to discuss some risk factors. So we all know that renal impairment increases the risk of gout. There's certain medications such as diuretics can. Metabolic syndrome is a risk factor. Alcohol is a risk factor. There's certain aspects to diet that I'll discuss. And sometimes cancer, because the cell turnover, the cell death, release of purines, increases the breakdown into serum urate, increased serum urate. And also, if psoriasis is really bad and there's high cell turnover, you can actually get gout associated with this as well. And then sometimes people just have the genetics where they are predisposed to gout. So I'll just remind you ourselves about the metabolic pathway of urate metabolism. So purine is the breakdown of the DNA in the cells, the adenine and guanine, and then that is metabolized by xanthine oxidase into uric acid. And this is where allopurinol and febuxostat affect the enzyme. Now, in a lot of animals, they have a urate oxidase enzyme that breaks uric acid down into allantoin, which is much more water soluble and can be excreted. But in humans, we don't have that enzyme. So if there is a reduction in the amount of uric acid that's able to be weed out, or there is an increase in purine catabolism and cell breakdown, then we get hyperuricemia, and eventually that can lead to gout. So let me just discuss diet. We generally talk about a diet where we reduce the purines. I'm just actually going to go back the slide, sorry. Purines are found in red meat, offal, seafood such as shellfish, scallops, sardines, anchovies, yeast-based foods such as beer, and a lot of people forget about Vegemite too. And there's certain vegetables such as asparagus, mushroom, cauliflower, and spinach. The vegetables don't tend to be such a problem in studies so far. So I'll just then lead to the next slide, where what we actually recommend. So we recommend a diet that's reduced in purines. White meat is probably better than red meat, and dairy is actually probably protective. We do recommend reducing the alcohol. Beer and spirits are probably worse than wine. We also recommend reducing high fructose drinks. So in America, when they had an overabundance of corn, they developed these high fructose corn syrups to sweeten the soft drinks. And associated with this, they've seen an increased prevalence and incidence of gout. And we do know that fructose alters the metabolism of to uric acid, and so a lot of fructose in the diet can actually lead to gout. This includes orange juice. Now you're going to say to me, well, orange juice is healthy. Why? What do you recommend cutting out orange juice? And no, what we generally recommend is a healthy diet filled with vegetables. We don't need to entirely cut out purines out of the diet, and they can still have fruit. And probably people are better off to have fruit than juices anyway because of the fibre content in fruit. So that's the general recommendation that I tell my patients for the diet. Now, an acute attack plan. So I would tell someone to give them a plan on how, if they get niggles of gout happening, to start on this straight away. I would generally start with colchicine, unless they've told me before that colchicine is not effective. So I tell them to have 2 tablets straight away, 1 an hour later, and then I'll decide whether or not I think they should have 1 twice a day or 1 3 times a day thereafter. I usually stop it after a week. If it's not effective then they really need to look at some alternative treatments for that acute attack. Colchicine is better if it is used straight up very early on in the attack and generally is not as effective later on. I decide whether to give them 2 a day or 3 a day based on the patient. If they're a little old, frail lady, I might even only give them 1 a day. If they're a big strapping bloke, I might give them 3 a day to 4 a day, maximum of 2 milligrams a day. And as I mentioned, I probably would only treat them for a week or until the attack resolves, and then they can stop it. If colchicine is not effective for them, I would generally use an anti-inflammatory as long as it's not contraindicated. And the type of anti-inflammatory, as I mentioned before, can be naproxen 1 gram daily, Celebrex 200 milligrams daily. It can be indomethacin. I just tend to find the 4 times a day dosing is usually a bit inconvenient. And if they can't have colchicine or anti-inflammatories, then I would use prednisolone. Again, some people need a higher dose, and some people can get away with a lower dose, such as 25 milligrams. Whatever the dose I start with, I would then reduce that by approximately 12.5 milligrams, so half a tablet, every couple of days, so that over the week they're off the prednisolone. And obviously that attack plan then needs to be altered depending on how they've responded in the past. Hopefully with good management, they don't need to use it very often. I need to go. So that leads me now to the management, long-term management. And really we use urate lowering therapies then for long-term management to try to rid the body's stores of monosodium urate. And that can take years to get them down to a good level, but hopefully get their serum level down to a reasonable level a lot quicker than that. Now the drug of choice at the moment is allopurinol. And when we lower the urate in the body, you can actually bring on a gout attack. So it's a little bit tricky. When do I start them on allopurinol? Well, if they've got tophi, if they've got a lot of risk factors that you know that they're going to get worse, such as renal impairment and heart failure, for instance, and if they've had 3 or more attacks of gout in the year, then I would start them on allopurinol. I wouldn't start someone on allopurinol with just 1 episode of podagra. When do I start the allopurinol? Well, it is best to start it 3 to 4 weeks after the acute attack has resolved. If you start it during the acute attack, you can prolong it and make it worse. So you generally, if you can, try to wait until that's over and then start the allopurinol then. Sometimes people have ongoing gout and you just need to start it and give them an acute attack plan to get them through. We generally start at a low dose at 50 to 100 milligrams and build up. And I'll come back to why that's a problem. But starting them on too high a dose can actually cause them quite a severe gout attack. So I start at 50 to 100 milligrams, 50 milligrams if they've got renal impairment, 50 milligrams if they've got current gout that you just need to start them anyway, and 100 milligrams otherwise. I increase that dose by 100 milligrams every few weeks until about 300 milligrams, when I would then retest the serum urate level. Now 2% of people can get a rash with allopurinol, and that would be the only reason, or a severe reaction would be the only reason why I would stop the allopurinol. If you start and then stop and start and stop, you're really going to bring on a gout attack. So they're better off to keep on going with the allopurinol even if they get a gout attack, and that's very important. They keep on going if they get a gout attack when you start the allopurinol, and you use the acute attack management plan to treat any acute attack that occurs over that time. We also need to give some background prevention while we're starting the allopurinol and while we're building it up to get to the target dose. The background prevention that we generally use is colchicine, if that works for them. 1 tablet a day should be sufficient. Sometimes they need it twice a day. An anti-inflammatory, as mentioned before, or prednisolone low dose, such as 5 milligrams a day. And that's usually sufficient, one of those, to prevent the gout attack while you're building up the allopurinol dose. And we do have a goal dose, a target level that we're trying to achieve. And that dose is based on the serum urate level. We want to achieve a serum urate level of less than 0.36 millimoles per litre. And we keep increasing the dose until we achieve that. So some people need 800 milligrams, 900 milligrams of allopurinol. I haven't seen doses higher than that, but they're the sort of doses that sometimes we have to try to achieve to get that serum urate level right. So the fourth rule is that we start long-term therapy in those that need it, and we go by the allopurinol rules. So back to our case. His acute attack is treated with an anti-inflammatory. In this case, it was diclofenac, 50 milligrams 3 times a day. Plus, he had intra-articular methylprednisolone, 40 milligrams, or better known as depomedrol. He was educated about gout, risk factors, diet, and there was a plan to follow up with a repeat serum urate when he was stable and consider commencing the allopurinol. Now, just a word about the serum urate. When someone has a gout attack, the serum urate can actually drop down. So it won't be necessarily, it won't indicate what their monosodium urate body load is at the time of a gout attack. So you're actually better off to check the serum urate when they're not currently experiencing a gout attack. He doesn't turn up for another 18 months, and at that stage his GP refers him back because he's had several episodes of painful swollen joints, including his knees and ankles. His serum urate was 0.56 millimoles per litre at that stage, and his GP had commenced him on allopurinol 300 milligrams a day only 2 weeks earlier. He now had a very painful right swollen knee. So what do we do? Should we stop the allopurinol? Just remember the fourth rule, allopurinol rules do not stop the allopurinol. So he probably has this worsening gout in his right knee in this most recent episode because of the allopurinol being commenced, and also straight up at 300 milligrams per day. So in this situation, I would not stop the allopurinol. I would keep it going at the same dose and treat the acute attack. So he does come back after 2 months. His allopurinol continues at 300 milligrams per day. He's on 1 colchicine a day now after he'd had his acute attack. I then had said to him to go back down to 1 colchicine a day and maintain that as prophylaxis. And he also had diclofenac there as a background for the acute management if he needed it. He hadn't had any further attacks at that stage. His serum urate is 0.43 millimoles and he has normal renal function. He had reduced his alcohol to 2 to 3 beers on weekends, and he was watching his diet. The first thing I'd do there is check his compliance. Make sure that he is actually taking his allopurinol before you increase the dose further, because really we want to try and get his serum urate below 0.36 millimoles per litre. But he did assure me that he was taking his allopurinol. So the next step is rule number 5. We treat to target. We titrate the treatment to the serum urate level. We want to increase his allopurinol further, so I increase it to 400 milligrams a day. Just be mindful that uric acid precipitates out as crystals at a serum level of 0.42 millimoles per litre, so we really want it below this. Otherwise, it's going to continue to cause problems. So we need sustained levels below 0.36 millimoles per litre. And if they've got tophi, we actually even want it lower. We want it closer down to 0.30. So the 5 rules of gout are we need to prove the diagnosis if it's not been proven before, especially if it's a monoarthritis, we need to consider septic arthritis. We want to aspirate if possible. We want to consider and treat the risk factors. We want to educate, write an acute attack plan and manage acute attack. Treat with urate-lowering therapy if needed, and remember the allopurinol rules, which are don't stop the allopurinol unless there's side effects. Wait until the acute flare settles and commence allopurinol 50 milligrams daily. Give background prophylaxis, either colchicine, an anti-inflammatory, or prednisolone, and continue the allopurinol even if they flare. Then we want to treat to target and titrate to the serum urate which is we're aiming for less than 0.36 millimoles per litre, increasing the allopurinol dose slowly. So the second case, I'm going to talk about allopurinol sensitivity and the other therapies, the future therapies. So he's a 53-year-old married male, Pacific Islander. He has chronic tophaceous gout, type 2 diabetes, hypertension, he has renal impairment and hyperlipidemia. These are his medications. Now he's been troubled by tophaceous gout for over 10 years, despite colchicine. It's causing him significant disability now. He's working in a warehouse, he has difficulty with using keyboards, it's sometimes limiting his mobility and he needs to use crutches to get around. Now his first episode was podagra, left first MTP joint. It spread to his ankles. He had recurrent attacks involving his right first MTP joint, his knees, and becoming widespread, including now his hands and his elbows. His last serum urate was 0.56 millimoles per litre. He's developed tophi at the pinnae of his ears, his forearms, his hands and his feet, and it's increasing over time. In fact, he's also had one episode of an infection of his tophus at the left index finger. He's had previous joint aspirations which confirmed urate crystals, which I remind you are the needle-shaped birefringent crystals, and he's also had aspiration of his tophus that showed urate crystals as well. So this is a picture of the pinnae of his ears showing tophus there, the white regions, which look like toothpaste if they're squeezed out. And this is the aspirate of the tophus, which shows the birefringent urate crystals. You'll note they're needle-shaped, and in this direction they're blue, and in this direction they're yellow. So that's under a polarizing microscope, and that's the birefringence of the urate crystals. Usually, when you do an aspirate, there's quite a lot of them, so it's pretty easy to pick up, as opposed to pseudo-gout, where they have it's a different crystal, it looks completely different, and it's a lot easier to miss that crystal. So usually if there is gout, you will see the uric acid crystals quite easily, unless it hasn't been processed properly and it's been sitting in the lab for too long and they've dissolved. So his other findings, his type 2 diabetes, his blood sugars are not well controlled, his hypertension could be slightly better controlled. He has a previous history of uric acid stones as well, but no active urinary sediment presently, and these are his current lipids. So previously he has had an allergy to allopurinol, and this was described as an erythematous maculopapular rash. He's had no angioedema. It was approximately 10 years ago that this occurred. Someone very brave re-challenged him in the last 12 months, and he experienced another rash. He's had acute attacks that have usually been managed by colchicine and occasional intra-articular methylprednisolone by his local doctor. In terms of his risk factors, he's not a smoker. He's previously been a moderate beer drinker, and now he abstains from alcohol, and his wife reports a strict diet. Unfortunately, some risk factors you really just can't change, and Pacific Islanders really do have the genetics that they're much higher risk of gout. In terms of allopurinol reactions, approximately 2% develop a pruritic maculopapular rash. It can be associated with fever, facial swelling, or an eosinophilia, sort of like a DRESS syndrome. There can be more serious reactions such as toxic epidermal necrosis or Stevens-Johnson syndrome, erythema multiforme, hepatitis, interstitial nephritis, or a vasculitis. And those with toxic epidermal necrosis, the mortality rate is quite high, it's 20%. Those that are at risk of developing allopurinol hypersensitivity are the elderly, those with renal impairment, starting at a higher dose, and also the HLA-B 508 allele. So 15% of the Han Chinese, Thai and Korean populations will have this allele, and only 1 to 2% of Caucasians. So the number needed to test to pick up this allele is about 250 Asians compared with 2,000 Caucasians. So this test has sort of become more available now, and if you have a patient that you want to start allopurinol, you're concerned, then it might be worthwhile getting this test through the pathology labs. The general pathology labs can do it, and they'll send it off. We really don't know what the mechanism of reaction to allopurinol is. You can't do skin testing for it, and you can't do the the RAS testing, looking for preformed IgE in the blood. There are desensitisation protocols that you can desensitise a person for allopurinol. The problem with that is if they do have to stop it for any reason or it is stopped, you have to go through the desensitisation protocol again. So what alternatives do we have in this fellow who clearly has an allergic reaction to allopurinol and really is in quite a lot of trouble with his gout? Well, we do know that 90% of gout is due to impaired uric acid excretion rather than excess purine. So we can use uricosurics. Probenecid is what's most available in Australia. The problem with probenecid is really that you need to have an adequate renal function to use it. You need to have a urine output of 1.4 litres per day at least, because otherwise they're at risk of uric acid stones, or it won't work. So a GFR of less than 30 mils per minute, probenecid won't be effective, and less than 60 mils per minute, it will be less effective. So I would only use probenecid in someone who's got pretty normal renal function, and that's not the case in our gentleman. Febuxostat is probably the drug I would use in this situation. This is another xanthine oxidase inhibitor like allopurinol, but it's non-purine based. It is quite different to allopurinol, so you can use it in the case of an allergy to allopurinol. I'll come back and talk about that in a moment. There's also uricases. So I showed you the urate oxidase enzyme that metabolizes urate to allantoin. Well, these are available. They're available on the TGA in Australia for tumour lysis syndrome. There's a couple of them, respiricase and pegloticase. There's also other uricosurics that are much weaker than probenecid, but they can lower the serum urate. There's things that you may not have been aware of. So losartan blocks the reabsorption at the kidney tubule. Lisinopril, ascorbic acid or vitamin C, calcitonin and fenofibrate all have sort of slight urate lowering properties. And then there is lesinurad, which is in trials at present, and that's a URAT1 inhibitor. I'll come back and talk about that. First of all, febuxostat. So that is a very long, difficult word, thiazolocarboxylic acid derivative, so not purine-based analogue. So it's different to allopurinol, but still inhibits xanthine oxidase. It's metabolized by the liver and biliary system, and so it can be used in mild to moderate chronic renal impairment without any dose adjustment. It can also be used in those with mild to moderate hepatic insufficiency. To date, we're not aware of any hypersensitivity reactions with this medication, and there seems to be less drug interactions such as with warfarin. But we do need to be more cautious with azathioprine and 6-mercaptopurine, as we need to be with allopurinol, because it will reduce the metabolism of these medications, and people can become toxic on these medications. With febuxostat, we do need to be a bit cautious if someone has severe ischemic heart disease and congestive cardiac failure, and I probably wouldn't use it in that group of patients. So in phase 3 studies, febuxostat was effective at reducing the serum urate at doses of 80 to 120 milligrams per day, and 67% versus 42% achieved that serum urate target of less than 0.36 millimoles per litre at 6 months. That was on a dose of 80 milligrams versus 200 to 300 milligrams of allopurinol. But as I mentioned, we're also not dosing our allopurinol effectively, so we may be able to use a cheaper drug by just pushing up the dose of the allopurinol. And I would be using febuxostat second line then if they can't take allopurinol because of an allergic reaction or serious side effect. Febuxostat has been shown that it may be more effective at lowering the serum urate than allopurinol. It does seem to be slightly more potent, and overall adverse effects seem pretty similar. In one study, there was more withdrawal due to gout flares and abnormal liver function tests compared with allopurinol. Febuxostat is now available in Australia on private prescription. They're 80 milligram tablets. The brand name is called Adenuric. The dose would be 40 milligrams a day, and then you build up to 80 milligrams daily after 2 to 4 weeks. So really, you just give them half a tablet. You can break it in half. It has the same rules as allopurinol because it's still affecting the serum urate. You can still bring on a gout attack. So you avoid starting it until an acute attack has subsided by a few weeks. You start at the lower dose of 40 milligrams and increase after a few weeks up to 80 milligrams. You do need the prophylaxis in the background as well, like you do the allopurinol. You don't start and stop the febuxostat unless there's a serious side effect that would you want to stop it for good. And you can, like allopurinol, retest the serum urate as soon as 2 weeks after you've changed the dose, and that should give you a representative level of the serum urate on that dose of the drug. So what about uricases? So the recombinant uricases that are available, or urate oxidase, they catalyze the urate to the allantoin, as I mentioned. It's present in most animals, as I mentioned, but not so much in humans. Well, we have respiricase, which is a non-pegylated form that comes from Aspergillus flavus. It's available in Australia for tumour lysis syndrome. We don't tend to use it for chronic gout because repeated infusions can actually cause problems. They can reduce the size of the tophi, including patients who have solid organ transplants. They can be used. There's case reports of it being used in tophaceous gout, but there's serious allergic reactions that can occur with repeated infusions of the uricase. There is another pegylated uricase that comes from yeast or porcine-derived uricases that are under investigation. Again, their feasibility will depend on their immunogenicity and whether or not they cause the allergic reactions. And the other thing to note about respiricase is that you can't use it in people with glucose 6-phosphate deficiency. So lesinurad is in phase 3 studies. It is, oops, sorry, I'll go back. As I mentioned, the main cause for a high serum urate is inefficient excretion of the urate by the kidneys. And URAT1 is the key urate transporter. So when you have the urate being excreted, it is actively reabsorbed into the kidney tubules and then secreted. Well, the URAT1 transporter is blocked by lesinurad and stops it from being reabsorbed back into the bloodstream. So just in summary, I would try to confirm the diagnosis of gout and treat the risk factors. You want to treat the acute attack and educate the patient so they understand what they're trying to achieve. They have to understand why they should continue the allopurinol and why it might be causing a gout attack and why you want to try and give them another medication to prevent and for how long. So I generally would continue that for a few months after you've reached that serum target level. If needed, you start urate lowering therapy. You reduce the serum urate to a target of less than 0.36 millimoles per litre. You start them on low dose to start with, allopurinol for febuxostat, and build them up until you achieve that target serum level. You don't stop the urate lowering therapy. You do not start during an acute attack if you can avoid it. And you use the background anti-inflammatory colchicine or prednisolone for a good 6 months or until the urate lowering therapy dose is stable for several months. And then I've just given you a slide here of further reading that there's some good systemic reviews there from the 3E initiative. Kay Ting has given a nice succinct update on the diagnosis of management of gout in MJA. And then you can also have the information sheets which are quite useful for the diet in gout and explaining gout to patients from the Arthritis Australia website, which can also be accessed through our national rheumatology website at rheumatology.org.au. Thank you.
Thanks very much, Tina, for a very interesting and comprehensive presentation. If any participants have any further questions, please type them in now. Tina, you didn't mention any imaging at all with regards to sort of diagnosis and management. Have you got any comment about the potential use of imaging in the diagnosis and management of people with gout?
Sure. So when we're trying to diagnose gout for instance, if in their feet, we would do an X-ray of their feet and look for evidence of tophi or the typical large erosions that can occur with gout. And they usually have overhanging edges. No, I didn't include any X-rays in my talk today to show you. So that would be the first imaging modality I would use. Most of the imaging is not particularly specific. On ultrasound, you may see debris around the joint, but you can't tell whether that's gout, like uric acid crystals, or whether or not that is due to calcium pyrophosphate, for instance. Sometimes you can be lucky enough to see changes at the knee where you may see what we call the double contour line that may be suggestive of gout sitting on the top of the cartilage, or in pseudogout or calcium pyrophosphate disease, we see the triple contour line where the crystals are sitting within the meniscus or within the cartilage as well of the knee. But they're not necessarily specific. There is some new imaging available. There's a couple of hospital radiology departments that it's now available for us, and that's called dual energy CT scanning. And that's a bit like the dual energy the DEXA that we use to look for osteoporosis, where it's two different X-rays coming in, and they can change the energy of those X-rays to pick up gout crystals. So that is really quite a step forward in terms of imaging for gout, where we can ask for, if we're not sure, for instance, in the hand, we're not sure if it's a seronegative arthritis or gout, we can do a dual energy CT scan, and we see these lovely green lumps of crystal, and be sure that that's gout causing that arthritis. So that's also available.
Tina, just with the issue in relation to education of the patient, to what extent, I mean, some people may take a bit of time to actually tune into some of the issues around diet and risk factors and so on. How important is that component around education, and is it a matter of directing them to relevant websites, or are there other things that you would employ to actually educate the patient?
Yeah, so I do talk to the patient quite a lot, extensively, in that first diagnosis of what gout is, because I think one of the reasons why gout is poorly managed is because of misunderstanding from the patient as to they'll start allopurinol, they'll expect it to fix their gout and they not have another attack, and then they get a gout attack when they start it because it hasn't been explained to them that this can occur, and if it does, to use the acute attack management plan. So I think it's a bit of education so they know what to expect. Diet is actually really important. It can really reduce the amount of acute events. Some people use allopurinol so they don't have to worry about their gout, but there's some unlucky people that will still continue to get gout unless they change their diet, even on allopurinol. So it is still quite important. But as I mentioned, we don't take the purines completely out of the diet. And I usually always send them to the Arthritis Australia website to use the advice about diet, because I think this is where a lot of myths abound. People always say to me, oh yes, you can't have an acid diet and you can't have tomatoes, when in actual fact there's no evidence for that at all. So in fact, my secretary said that to me today, and I had to sort of say, well, no, actually that's not the case. I would have thought my secretary would know better. But so really, diet is very important, and we need to try and educate them properly. And there's still controversies in the diet, so I guess what we're trying to do is just give them a sort of a healthy middle ground of what should be used.
And you mentioned earlier also about in one of your cases where a GP referred a patient to you. At what point, would you recommend that GPs do actually sort of refer a patient onto a rheumatologist rather than sort of proceeding with management at the primary health level?
I think it comes down to how comfortable the local doctor is in managing gout. So if they want to send off to a rheumatologist to start with, that's fine, and then we get them back to the GP to carry on once they're at a stable level. So sometimes I've done that. Other times people have been started, it's fine, but it's not working, so we need to look at what's happening there, whether or not we can tweak and improve things. So I think it comes down to where the GP's interest lies and where they're comfortable. So I would say if the treatment is not working for whatever reason, then we may need to look at, well, is the diagnosis correct? Many a time there has been a diagnosis of gout, and in actual fact it was dactylitis from a seronegative inflammatory arthritis. So I think if there's a question about the diagnosis or if the management's getting tricky would be the main reason why you would refer on.
The person is on allopurinol for about 10 years but has not had a gout attack for more than 3 years. Is it recommended to stop the medication?
So the general feeling is once they have gout, they've got gout and they've got it for life. So it's probably one of the reasons why I don't start allopurinol straight up. You do want to be sure of the diagnosis because very few people come off it, or very few people are taken off it once they're put on it. If there's any hint of uric acid stones, I would never take them off the allopurinol. And the general feeling is that they're on it for life. Would I reduce the dose? You may be able to reduce the dose if the serum urate is staying low and cut that down. But no, I probably would continue it.
And just going back to that sort of increasing prevalence of gout in Australia, is it because of the increasing age of the population that we're seeing more gout in the Australian population?
I actually think it's probably a combination of factors, but I'm not entirely sure because these are epidemiological studies. But yeah, we're seeing an ageing of the population, and age is a risk factor, so that's probably one contributor. I think also our diet puts us at higher risk. We're eating a lot more meat in our diet than ever before. We're drinking a lot more alcohol as well, so I think that the combination of the diet, aging, as people age, they tend to have less renal function as well. So I think that's all probably contributing.
Okay, it looks like we don't have any further questions for this evening. So look, Tina, thank you so much for a very interesting presentation, and I hope that the participants found it really informative on what is a very important issue and an issue of increasing prevalence in the community. So Tina, thanks once again. Thanks to everyone for participating tonight, and could I remind you to take a moment to fill in the exit survey, which will be always useful information for us. So on that note, thanks everyone and good night.